ST segment elevation. That is the topic today, medics. How many times have you gone on a call, you saw ST segment elevation, and you're like, why aren't they having a STEMI? Why isn't my life pack saying they're not having a STEMI? So, we are going to go over some of the differentials of ST segment elevation so we can kind of close the gap between ER physician and medic. And that's pretty much the point of us further learning so we can become better clinicians when we're on scene and we're reading these 12 leads. Now, I know some of you are saying, well, if I have ST segment elevation, I have to call a STEMI no matter what, so what does it matter? Technically, you might be right. But this podcast is geared more towards the medic who wants to learn more so he can be a better patient advocate, so he can be a better, or she can be a better clinician on scene. This podcast is not for the medics who don't care. They just want to go through the steps. That's fine. But for those of you who want to learn some more, let's do it. ST segment elevation. Well, there's many different causes of ST segment elevation. The best mnemonic that I could find or think of, which I didn't think of, I found it, is elevation itself. And we're going to start with E for electrolytes, and that's when we're mainly talking about our potassium hyperkalemia. L, left bundle branch block. Early repose, our second E. Ventricular hypertrophy. We have A for aneurysm. T is for treatment, and we're talking mainly about pericardiocentesis. Infection and injury, which is our pericarditis and our MI. Osborne waves for our hypothermic patients, possibly hypercalcemic patients, and non-occlusive vasospasm. But we got to throw in a B because we got to give Brugada syndrome some love. That's what we're going to go over today. We're not going to go too much into the treatment aspect of it, pericardiocentesis. All we're going to say about that is if you're doing a pericardiocentesis and notice ST segment elevation, it might be normal. We're not going to talk too much about non-occlusive vasospasm. That is our angina patients. If you see chest pain, ST segment elevation, well, that's going to kind of go hand in hand with our infarction. So getting on to it. Hyperkalemia. Now, what are the classic EKG changes of hyperkalemia? Well, the books are always going to say you got the classic 5, always in that order, as opposed to, according to the book. We get the tall peaked T waves, we get prolongation of our PR interval, then we get our absent P waves, then we get a wide QRS turning into a sinusoidal pattern or eventually VFib. All right? But patients don't always follow the book, and there is no evidence that correlates potassium levels to any one of these EKG changes. So if you see any of this, we have to be able to recognize that there might be some type of electrolyte problem. So here's a pattern of our classic hyper K, right? Almost normal. Got a little bit widening of our T wave here. Losing our P wave, we get that peaked T wave here. Then we have a losing of our P wave, QRS widening, turning into a sinusoidal pattern. That is what tests love. That's what you have to learn for your exam. But keep in mind, your patient might not present that way. So here's a 12 lead of a patient with hyper K. What am I looking at? Well, the thing that stands out to me the most are these tall peaked T waves. Now, you have to imagine that this T wave here, if you were to sit on that, it would hurt, right? Pointy. And they also call this the Eiffel Tower complex, right? We got a pointy T wave and a very narrow base. Also looking at this T wave, we're noticing another thing. We also notice that we have a slurring up here of our ST. It's not flat, it's not straight across. And my T waves are symmetrical, meaning my upstroke and my downslope are symmetrical to each other. Symmetrical upstroke, downslope, pointy, very pointy T waves, peaked T waves as they're called, are very classic for hyperkalemia. Also, look at the size of this T wave in relation to my downward QRS complex. It's almost the same size, yet it's very big even for early repolarization or hyperacute T waves, which we're going to talk about later. But this is a very big T wave in relation to my downward deflecting QRS complex. So that is a hyperkalemic T wave. Let's look at another one. All right, what do I got? I got a symmetrical T wave peaked. Here you can see it really good in V4. Symmetrical T wave and peaked. All right. That is another classic hyperkalemic T wave. All right. So if we're seeing some ST segment elevation associated with T waves that look like this, it might not be a STEMI. This might be hyperkalemia. So what am I looking for my hyperkalemic T's? They are peaked in the leads with the elevation, and remember, ouch. These T waves are going to look like they're going to hurt if you sit on them. They are symmetrical up and down strokes. Your QRS complex will sometimes be wide, usually greater than 120 milliseconds, and we might see some ST depression in other leads. That could be normal. All right, so that is our hyperkalemia. Well, left bundle branch block. That is the L of our mnemonic. The bane of every paramedic's existence. A patient with left bundle branch block. We don't have old EKGs to compare. We don't know if this is old or new, so we have to presume that it's new unless the patient is absolutely astute on their diagnosis, so they might be able to tell you they have a left bundle branch block. But unless you can see an old EKG or the patient has their history written down, you have to presume it's new, and then gotta call a STEMI. But is there a way to look at a left bundle branch block and kind of tell whether or not the ST segment is normal or abnormal? Well, there sort of is, and that's what we're going to talk about today. All right. So what is normal for a left bundle branch block? Well, they're usually going to be wide. You're going to have some ST segment elevation. All right. But what we're looking for is what they call discordance. And more importantly than that, we're looking for appropriate discordance. So what does that mean? Well, excuse me. Discordance is when your ST segment is going in the opposite direction of your prominent QRS complex. That is discordance. Concordance would be when your QRS complex is going in the same direction of your QRS complex. In a normal left bundle branch block, discordance is normal, but appropriate discordance is normal, meaning that for discordance to be appropriate, it would have to be less than 5 millimeters, which the sensitivity of that isn't exactly high, or it's around the 20%, as I've read. So in those situations, we might have to look at voltage criteria, and we'll talk about that in a minute. So all that in mind, we're thinking about Sgarbossa criteria. So what is Sgarbossa criteria? Well, let's talk about that. Sgarbossa. ST segment elevation greater or equal to 1 millimeter concordant. That means in the same direction as a predominantly positive QRS complex in at least one lead. That's worth 5 points. Anything greater than 3 points on Sgarbossa criteria equals STEMI. All right. We have ST depression greater or equal to 1 millimeter in leads V1, V2, or V3. That's worth 3. And then we have our ST segment elevation greater than 5 millimeters. That is discordant in the opposite direction of. That is the too much of a good thing. But because the sensitivity is so low, Sgarbossa only gives that 1 point. You might have to look for voltage criteria, and we'll talk about that. So what is discordance? Well, thanks to EMS12lead.com, which if you have not checked out that site, you have to. The site is awesome. EMS12lead.com. I stole this picture, and in this one we have an upward QRS complex with a negative T wave with some J point depression. This is discordance. That's normal. Look at B here. We have a downward deflecting QRS complex. We have an elevated J point, less than 5 millimeters. It is discordant ST segment elevation in relation to the QRS complex. That is discordance. That is normal. That's what you want to see on a left bundle branch block. Let's talk about